Hey there, fellow platypi. Welcome to another installment of our PS Platypus clinical skills lectures in the context of the respiratory system. Today, we're going to be having a look at some of the major investigations and devices that are used in this space. The main thing is just to put this into context. So remember that when we do a history and examination, those are going to be the key places where we make about 80 to 90% of our diagnosis of any pathology, whether it's respiratory system or any other system. These investigations are mainly just to confirm what we think is already happening with the patient. So not things we would be doing first line, but things we would be considering once we know, for example, that this patient is at a high risk of pulmonary edema or pleural effusion, just to confirm that is the case. So with that out of the way, the three main things we're going to be discussing are going to be how to interpret a chest X-ray. So I know you've seen a lot of these during our anatomy lectures, during our clinical skills or clinical reasoning lectures from last week. But today is just to consolidate all that information, bring it back to some of the simple steps and procedures that are required to interpret any chest X-ray at all. Then we're going to briefly have a look at the peak flow meter and how to analyze that, as well as a little bit on the asthma devices that you're expected to know by the end of this year. So let's get started. Firstly, when we come to the chest X-ray, it's really important that we know what the normal chest X-ray looks like, because without having this as a baseline, it's very difficult to tell what is abnormal or what is a pathology. So on the left-hand side here, I've got an unannotated diagram of what a normal chest X-ray looks like. And importantly, it's very crucial to know that when we're doing a chest X-ray, I know that we're in the respiratory system, but we're not just looking at the lungs. We are definitely going to also look at some of the other structures that are present in the mediastinum and the thorax in general. So of course, you can see the lungs, or rather you can see the air within the lungs. So you might not be able to see the tissue, but you can see the vascularity, and you can see these black regions representing the air. You can also see the heart smack bang in the middle, kind of deviated a little bit to the left-hand side as normal. And it's really important to be able to tell the different parts of the heart. So not just that this is the heart, but what does this border represent and what does this border represent? And that's important because we can have enlargements of those regions of the heart. Also important is, of course, this is an X-ray, right? So we're going to be able to see a lot of bones. In this case, you can see ribs, you can see scapulae, you can see the clavicles, you can have a look at the vertebrae. So that's super important that you can analyze those for things like fractures or dislocations, anything like that. Also, there's soft tissue, right? So I've already discussed the lungs, but also look at the muscles. You can see the diaphragm at the bottom. Got that classic dome shape to it, which we'll go over in a couple of minutes. And you've also got the trachea that's coming down. So while you can't see the lungs themselves, you can see the trachea bifurcating into the two main bronchi and then eventually penetrating into the lungs via the hilum. On the right-hand side, just to give you a bit of an idea of the level of detail that you're expected to know when it comes to anatomy, this has all been labeled with some of the really important anatomy that we would have covered this year in RESP, as well as last year in cardio. So of course, note some of the bony structures, and this should all be quite easy to kind of identify from these X-rays. The difficult parts could be when it comes to actually identifying the lobes of the lungs. Of course, you probably won't be able to see the actual fissures unless there is a consolidation in one of the lobes. So you can ignore these fissure lines for now. The main thing is the fact that you can see the vascularity of the lungs, and then importantly, the heart itself. So remember that when you're looking at the borders of the heart, on the left-hand side, you're mainly looking at the left ventricle, just because of the way that the heart is oriented, pointing to the left. And of course, this is going to be where the apex beat is located. On the right-hand side, you will notice a little bit of the right ventricle, but because again of the way that the heart is squashed and oriented, pointing in one direction, you're actually mainly going to be looking at the right atrium wall on the right-hand side. So left-hand side is left ventricle, right-hand side is more right atrium. You probably also will be able to notice a little bit of the great vessels that come in and out of the heart itself. And the most important one to recognize is the aortic arch, which on X-ray, we sometimes call the aortic knob. And finally, outside of the thorax itself, you'll be able to see the muscles. So you'll be able to see the diaphragm, but you'll also be able to see the gastric bubble in the stomach that's underneath that. So we'll get into that once we get to the interpretation. But it's just super important to know what to expect to see when you are given any thorax or chest X-ray. All right, but the main point of this seminar is just to be able to give you a systematic way to approach any X-ray. So whether it's an examiner that's giving it to you in an OSCE, or whether it's a clinician when you're in the clinic and they give you a chest X-ray and ask you, what's happening with this patient? What do we think we need to do from here in terms of management? It's really important that you have a systematic way of approaching things so you never forget any specific signs. Now, in a similar way to ECGs, I'm going to keep drawing comparisons to what we did last year. It's super important that we keep in mind that if we analyze an ECG or an X-ray or whatever modality, and the actual film or the actual graph paper is wrong from the beginning, it doesn't matter how much we analyze it, the faulty image that we're given is not going to yield us any information. So what I mean by this is when we see a chest X-ray, the first thing we need to do is figure out, have we got the correct patient in front of us as the one that's been labeled in the diagram? And secondly, is this film actually devoid of any errors that may mess up my interpretation? So when it comes to doing the correct patient, it's quite simple. Of course, in this diagram here, you've only got the X-ray, but you probably will have a report at the bottom, which will have the patient's name, the patient's age, date of birth, as well as their specific patient number, so the URN. Make sure this matches with your record so that you don't, embarrass yourself going up to a patient who this chest X-ray is not even for. Also, very important is to actually recognize when was the chest X-ray taken. The reason why this is the case is because if you see a massive pleural effusion on a chest X-ray, and maybe if you have done a chest X-ray yesterday and there was nothing there, or if you did a chest X-ray yesterday and there was still that pleural effusion there, which one would worry you more? Well, of course, if there was no pleural effusion yesterday and there is now today, and it's a massive pleural effusion, that would worry you quite a bit, right? Because it's been an acute change. Whereas if this is something that the patient has had for 2 weeks, 3 weeks, and they seem to be doing fine, that may reduce your threshold for red flags popping off in your mind, right? So you want to have a look at this X-ray, and if the previous one is available, have a look at when that was taken and what you can see there. In terms of the film itself, most chest X-rays are actually taken from a PA view, so from posterior to anterior. Some are taken laterally, depending on the positioning of the patient. Sometimes you will have emergency settings where the patient is not even able to stand up, and you'll do an emergency chest X-ray while they're lying supine or prone. Generally, also the chest X-rays are taken in the inspiration phase, so with the patient breathing in. But I'd also always recommend not to assume anything. Always check in the patient notes, or if you can tell from the X-ray itself, figure out what sort of angle you're looking at the patient in. And then finally, any technical errors. So in a similar way to ECGs, where you're looking for the calibrations, you're looking to make sure that the line itself is isoelectric. For the chest X-ray, you're doing a very, very rapid assessment just to make sure that there are no errors there. So the mnemonic that I like to use, or the one that is prescribed by faculty as well as pretty much everywhere online, is the mnemonic RIPE. So rotation, inspiration, picture, and exposure. I'll walk through these very quickly, but if you want more information, you can search it up online. So rotation is super important. What it tells us, as the name suggests, is the patient sitting straight or standing straight, or have they been shifted to a particular angle? Why is that important? Well, if I'm on an angle, it might artificially seem like one side of the chest is actually much larger than the other. So either I might think, if they're rotated like this, maybe the left lung looks very big, or maybe the left ventricle looks really, really big, but it's just because they've been rotated and it's artificially so. So the way that you can tell if something is, or if the film is rotated, or if the patient is rotated, is to have a look at the medial ends of the clavicles on either side and see if they are equidistant from either the spinous processes, tends to be a bit more reliable, or you can check whether they're equidistant from the trachea. Reason why I say the spinous processes are a bit more reliable is because the trachea could be deviated, and so it might not be the best way to calibrate how far the clavicles are. If they're equidistant, you can move on. In terms of inspiration, as I said, most chest X-rays are taken on inspiration, but there are some patients who might not be able to breathe in very well, so you would not be able to get full exposure of all the lobes of the lungs. Conversely, there might be patients who you see too many ribs. So you might be able to see, 10, 11, all 12 ribs at some points because they've been hyperinflated, for example, in the case of COPD. Generally speaking, just in terms of rough numbers, when you're checking for inspiratory effort, you should be able to see about 5 to 6 ribs on the anterior side, or like when you count them from top to bottom, from the top, meaning the apex, to the bottom, where it kind of stops at the diaphragm level. And if you're looking at the posterior ribs, then probably about 8 to 9, at a stretch, maybe 10, but 8 to 9 is generally the accepted number of ribs to count. Picture-wise, you're just having a look very, very generally at how, like, what the picture sort of looks like. Is it grainy? Is it actually well-defined, etc.? Of course, having a look at the angles and the view and things like that. And finally, exposure. This is just saying like how much penetration is there with the actual radiology that's been done. So the easiest way to tell this is, can you actually see stuff that's behind the heart? If, for example, you can only see the heart and you can't see any ribs or spinous processes or vertebrae behind it, then there might not be enough exposure because it's supposed to go all the way through to the very posterior surface. Again, another easy way to tell is like if just the general film looks very, very dark or way too overexposed, then that's a sign that they haven't done this X-ray correctly. All right, now let's get to the alphabet part. So A, B, C, D, E, F, G, H, I. When it comes to A, we're looking mainly at the airways. On the right-hand side, you can see I've just put the normal chest X-ray for reference, but I'd also recommend you have a look at some abnormal variations of this, which I'll show in 2 slides time. So airways, main things are tracheal deviation. So in a similar way to how we're looking at whether the clavicles are equidistant, you can have a look at whether the trachea is actually midline or not. Also, you might want to have a look at widening of the angle of carina. You might remember back to anatomy that you've got these lymph nodes just sitting underneath that V-shaped angle of carina. If you've got widening, it could be a potential sign that there has been some sort of metastasis of cancer into those lymph nodes. But of course, it could be many things. Bone-wise, quite simple. You're just looking at all of the bones that you can basically see in the entire X-ray, especially for fractures or chest wall traumas, deformities, anything like that. Cardiac-wise, very important to check for cardiomegaly. So generally, the transthoracic ratio should be about less than 0.5. So what you're doing is you're basically measuring, okay, from the very left-hand side to the, or in this case, this is the left-hand side, very left-hand side to the very right-hand side, measure the distance, and then measure the distance that or the diameter of the heart in the same direction. If it's less than half of the total width of the mediastinum, then you can be, then you won't be concerned about cardiomegaly. Very, very important though to check whether this is a PA or an AP view, because generally when you're in an AP view, the heart will actually look a little bit larger than when it's in a PA view. So it might look like cardiomegaly, but it probably isn't. Okay, so keep that in mind. Also, can you identify the aortic notch? So that's the place that I mentioned about the arch of the aorta. You can kind of see that here. That's kind of where the ascending aorta comes out, becomes the descending aorta as it passes through the arch shape. And then finally, are the cardiac borders themselves visible? So I can see the left border, which is for the left ventricle, right border for the right atrium. Importantly, for the right atrium, if you can't see the right atrium and you can see these really like an opaqueness to the lung fields on that side, you might be concerned about some sort of consolidation, because what's happening is that consolidation, which is most likely to be in the middle lobe of the right lung, is actually covering up the visibility of that side of the heart. Okay, if you can see that border and you notice that there is still that opaqueness in the region, then you're more concerned about a lower lobe pathology or a lower lobe consolidation. And I think you can search this up online just to tell what the difference is. So a lower lobe versus a middle lobe on the right hand side. But the key distinction between them is that they both look like they're in the same area, because anatomically they kind of are. But the only difference will be the fact that whether you can see that border or not, because the middle lobe is more in front, posterior lobe is more at the back. Then you look at the diaphragm. So remember that the diaphragm has 2 hemidiaphragms, or kind of domes. Sorry, I forgot the word there. You've got domes, right? Relatively speaking, the right dome should be a little bit higher than the left one, just because you've got the presence of the liver. But of course, there can be situations where either the domes are extremely depressed or flattened in cases of hyperinflated lungs and COPD, or you could have a dome that's way too high, right? So you want to note those changes. And then, is there any air underneath the diaphragm? So that can be a sign of pneumoperitoneum. So when we get to abdomen, you will quickly realize that there are many places in the GI tract where you can get perforations, gas can escape, and because gas is quite low density, it'll rise up and settle underneath the diaphragm, and you can actually really easily see that, generally on the right-hand side because it's a bit higher up. Now we come to the next couple of letters. So E for edema, very, very easy. You're looking at the costophrenic angles on either side. So costophrenic angle here, costophrenic angle here. If there's any blunting, then we are concerned about a pleural effusion. And of course, the more it's blunted, the more severe that pleural effusion probably is. Then you look at the fields of the lungs themselves. So fields meaning just look at the lungs in general. Can you see any opacities? So obviously in a lung, you should see more air, which should be black. But if it's kind of faded or white, then you might be concerned about an opacity due to potentially consolidation. And normal lung marking. So that's indicating the vascular supply of the lungs themselves. And I can see that quite well on this lung, both on the left and right-hand side. Gastric, again, very straightforward. You're looking for the gastric bubble on the left-hand side. So the stomach is on the left, just underneath the left dome of the diaphragm. So that can sort of be seen here. And that's a normal finding, okay? So you don't need to be worried that that's some sort of pneumoperitoneum. Then in the hilum of the lungs, this is a bit low yield. You probably won't be able to see this very well. The main thing is just to have a look at the relative positioning of the hilum. So generally the left-hand side tends to be a little bit higher than the right-hand side, but again, not really that important to actually observe. Sometimes you won't be able to see it very well. It's also a good opportunity just to have a look at some of the other mediastinal structures that could be present around these regions. But again, over here, not very significant. And then finally, look for instruments and extra bits and bobs that you can see on the X-ray. So depending on what situation and context this patient is in, you might be able to see some foreign objects, especially if they've inhaled something and it's gotten stuck somewhere. You might be able to see some tubes, so nasogastric tube. You might be able to see an endotracheal tube. As the name suggests, you can kind of expect them to see in specific parts of the chest X-ray. You might be able to see some ECG dots placed around the patient if they haven't had time to take them off, as well as ECG wires. You might be able to see central lines, PICC lines, that kind of thing. Any implants, so for example, a pacemaker, and just other random stuff. For example, in female patients, you might be able to see the bra line. Also, obviously in female patients, you'd be able to see shadowing of the breasts. So just keep that in mind. And you will look really smart if you get to this point and you, for example, notice that this patient is supine, they're probably on a bed or something. They still got their ECG wires and things like that attached. Like they've got a lot of stuff attached to them. So you might be wondering, okay, is this an emergency admission? They probably haven't had enough time, or like this is such an emergency that they haven't had enough time to really like take everything off the patient, take their clothes off, take the ECG wires off. They just have to do it really, really quickly. Okay, so that's the main sort of couple of things that you're looking for when you get to a chest X-ray. And as long as you stick to the systematic approach, you will never forget anything important. Now, of course, when it comes to actually analyzing a chest X-ray, whether you've seen it in TV shows or whether you've seen it in real life, most people wouldn't go through the entire A to I approach, right? Because if you see something, you'll probably name it first, right? If it's really, really obvious. But the previous approach is more so if you absolutely have no idea and you just want to take off everything on the checklist. Sometimes you never know. You might be actually looking at a normal chest X-ray, right? So you want to be really careful. However, these are some really common lung pathologies that if you were to see it given to you, you can almost immediately tell what has happened to this patient. So what I'd recommend is as I show these images, maybe pause the video and have a go at yourself going through the systematic approach and trying to figure out what's happened with these particular images. So first one here, I'll give you a couple of seconds just to think about. I want you to have a look at specifically the lung fields themselves, right? So you know that we're looking for normal lung markings, we're looking for the lung borders, etc. Hopefully you've had a chance to have a look at this. What you'll notice is that on the right-hand side of the patient, so you can tell because it says R here, it says left here. On the right-hand side, you can see normal vascularity. In fact, what you might be able to notice though, is that the lung has sort of been pushed a little bit to the, like a bit more to the right-hand side. You can see these borders here and just map it around. You can see the entire lung on the right-hand side, full of vascular lines. However, on the right-hand side, sorry, on the left-hand side, you'll notice that I can't see any of those lines anymore. All I see is air, right? Just black air throughout the whole thing. And if I notice very closely, you will see that you can actually see this little sort of lump right over here. And you might mistake this for potentially the heart, but what this is actually is because you can see the heart here, that's actually a grossly deflated lung right there, okay? And this is probably because this patient has a tension pneumothorax. So what's happened is the air has filled inside here, it's caused this lung to collapse, and then all of the contralateral mediastinal structures have been pushed even further laterally, okay? So this is very classic of a lung collapse, potentially due to a pneumothorax. Now this image, again, have a pause, just have a think about what's happening here. Now, just to clarify, these are quite like, I guess, like pathognomonic images. They're kind of exaggerated. So these are the worst case scenarios. You want to be looking out for these in more subtle appearances. But in this case, this is actually quite an easy diagnosis to make. This is pulmonary edema. So you will be able to see a lot of fluid and a lot of congestion in both of the lungs. So in this case, we had nice, healthy, kind of more subtle vascular markings. Over here, you can see a lot of fluid just building up in those lungs, right? So very, very classic of pulmonary edema. Now this next lung here, this is actually, sorry, the same lung. Now it's swapped to a new one. So have a look at this one and have a think about what you think could be happening here. So have a pause, have a think. All right, hopefully you're back and you have some sort of idea. If you have a look at, again, the left-hand side of the lungs, you'll see it's quite normal. It's got the normal vascular lines, etc. But on the right-hand side, you may have immediately noticed that there's this band of like opacity, right? You've got this band of opacity running through the lung. This is classic of some form of consolidation. And it seems to be kind of like a regional consolidation, right? It's not like a patchy consolidation. It seems to have affected a lobe, like an entire lobe or part of a lobe, at least at this point. So in this case, we're thinking it's potentially some form of pneumonia, and there has been some form of consolidation to accompany that. And then finally, this one here is like very, very extreme, as you can tell. You can see again on the left-hand side, lung looks quite normal. And you can actually see that costophrenic angle quite nicely, right? It's quite sharp and normal. But on the right-hand side, I mean, it's quite obvious, right? Like you can't see the costophrenic angle, but also you can't see much of the lung at all past that point. So what's happened here, and again, it's this opaque region. This is not a consolidation. This is a pleural effusion. Okay, so the reason is you've got fluid building up over here. You've got that blunting costophrenic angle. The fluid continues to go up and up and up and up and up. And sometimes you can notice this minuscule sign where, like, if you imagine that you've got fluid, it kind of forms like a little U shape, which you can sort of see here with the fluid. Okay, so that's built up on the right-hand side. So that's just a quick crash course into chest X-ray interpretation. I just got 2 more slides very, very quickly talking about peak flow as well as asthma inhalers. Now, your clinical skills booklets do a really good job of going through this, so I'm not going to add on the exact same details, but this diagram pretty much explains every single thing you need to know. So this is showing the normal values for the peak expiratory flow rate when you take someone's peak flow recording. The really important high yield bits of information to know is, even before this, just if you can, get your hands on one of these, or at least look at a video online on how it's being used. It'll set you up really well for your clinical years when someone just gives this to you and says, okay, can you measure the peak flow of this patient? At least you've seen it before and kind of seen how it's used. The next thing is that this diagram, you'll notice that there's many lines. So the normal values are very dependent on the age of the person, the sex, so whether they're male or female, and the height of that patient. As you can tell, each of these lines is for a different height. Tell the patient to blow hard and fast into the mouthpiece. It should be quite well sealed. And do this 3 times, at least with 3 attempts. And the reading you're taking is not like the average of those 3 attempts. It's just the best one out of all of them. Ask the patient to sit upright. Try not to have them leaning on it unless it's an emergency situation and you can't actually get them to sit up. And of course, with practice, you will realize that every single time you do these attempts, you want to push back the marker to 0 so that you have no confounding errors at all. So probably the most important mistake that many students make is that they don't read the diagram properly. So if you've got an exam, the age of the patient is 45, they're a male, they have a height of 183 centimeters. What is their expected peak expiratory flow rate? Make sure you've identified those numbers very well, and you can kind of like cross-reference them and find out the exact point that they convalesce on the line itself. Okay, so that's the most important thing, is to read the graph very carefully. Now, asthma delivery devices, there are so many of them, and so many of them are invented, every single year. This diagram has probably become outdated, but it's from, I believe, the National Asthma website. So if you want to have a look at the most updated version, that should be there. It kind of shows you the vast range of things that you'll be able to see in patients who come to you with the different medications. So the classical ones would be just the normal aerosol metered dose inhalers. So kind of these ones here, and you can see them in all sorts of forms. So you've got the SABA relievers, you've got the corticosteroid preventers, you've also got combinations and so on, right? So that's the classic one. So you just got the puffer. They're the commonest ones. So definitely sit down and learn how to use them. If you don't have your own, just watch a video, or if someone like a friend or someone in your family has one, just have a look at what it looks like and how they use it. Oftentimes, especially in children, we like to use spacers. The reason why is because if you have a spacer, the gas kind of the drug kind of stays there for a longer time. So it means that the child or whoever is requiring a bit of extra support, they're able to kind of breathe in for a longer period of time, maybe take 4 or 5 breaths before they take the next puff. Importantly, you want to clean the spacer with warm water and air dry it rather than drying it with like a towel or something, because you don't want any static electricity, which if it's present, it'll cause the drug to just cling to the spacer, which is not getting into the lungs. You also want the patient to take really deep breaths, right? Because there's no point if the drug kind of just goes and gets around their mouth or in the upper airways. You need it to go all the way down to the lower airways where respiration is actually happening. Kind of importantly as well, you'll learn about this in pharmacology. If they don't breathe in very deep, especially if it's a steroid kind of gas, what's happening is if it's staying in the mouth, it's just going to cause them to develop things like thrush because they've lost the immunity around that area. So you need it to go all the way down to have some sort of positive effect. And then finally, you can have a read about some of these more niche ones, as is mentioned, like the AccuHalers and other types of things that you can see in this diagram and in your booklet. But really just like read them once and toss them out the other side, because you're not going to see them very often. And when you do see them, you will learn how to use them, right? You don't need to learn how to use them now. The critical thing that you want to know about asthma delivery devices is just how to educate a patient on how to use them. So sometimes in an OSCE scenario, it'll be just an explanation station where it says, this patient has come in with severe asthma. They want to learn how to use the aerosol MDI inhaler that's on the table in front of you. Can you show them how to use it? So being able to explain to them, you have to uncap, check the expiry date, shake it for a little bit, puff, breathe in, how many times you have to puff, etc. It's a very, very important skill because you'll be doing it a lot when you get into the clinic, or if you are thinking of working as a GP or just in general, okay? So that's the main things that I wanted to cover in this lecture today. As always, if you do have any questions at all, feel free to either message me privately, pop it in the comments, or use the CuriousCat if that's still working. Best of luck for the rest of your lectures. And do let us know if there's any other extra topics that you'd like us to cover in the coming weeks that, for example, have not been taught very well, either in previous weeks or by the faculty. Okay, awesome. Well, again, best of luck, and I'll see you next time. Bye.